Hi, my name is Dr. Nita Vangeepuram. I'm an assistant professor in the Department of Pediatrics at the Icahn School of Medicine at Mount Sinai, and practicing general pediatrician. So in general, almost 200,000 youth in the United States have diabetes, and that's all types of diabetes. Um, there are two main types. One is type 1 diabetes, which is the type of diabetes that children develop generally at younger ages. And it's when the body doesn't make any insulin, which is the hormone that regulates the sugar in the body. So we used to only see type 1 diabetes in kids, and now more and more of it is actually type 2 diabetes. And the rate of new cases of type 2 diabetes in children and adolescents younger than 20 years is actually increased by almost 5% per year over the last 20 years. And we know that there are very clear racial ethnic disparities in these diabetes rates, where new cases in racial ethnic minority populations are more dominantly type 2 compared to type 1 diabetes. And the largest increases have been among Asians and Pacific Islanders, followed by Hispanics, and then non-Hispanic Blacks and American Indians. So there's certainly not an equal burden of the condition across all populations. So there are many factors that contribute to these increasing rates of type 2 diabetes. And when we think about diseases, we always think about modifiable and non-modifiable risk factors. And what I mean by that is modifiable things are things that you can change. These are things like lifestyle, namely diet and physical activity. The non-modifiable are things like having a positive family history or your genetics, and there's really nothing we can do about that. But when we think about how individuals and families make choices about the modifiable things, their lifestyle, we can't ignore the role of the physical environment on these decisions. And there have been lots of studies that have shown that, for example, certain neighborhoods have more corner stores or bodegas, which tend to carry less fresh produce. They don't have as much low-fat dairy options. They tend to have more junk food and sugary drinks. These neighborhoods also tend to have more fast food restaurants, especially near schools, and relatively fewer supermarkets. And then even if healthier foods are available, there may not be as much variety, and high cost may prevent families from purchasing these healthier foods. And in terms of physical activity, a lot of these same neighborhoods often have limited affordable resources like gyms or structured physical activity for after school, and safety concerns like crime can also prevent the use of publicly available outdoor spaces. So the physical and neighborhood environment play a large role. So we know both from looking at what's happened in adult diabetes prevention and even in kids that the most effective prevention strategy is weight loss or not gaining weight, and which really involves modifying your lifestyle. And so we've seen studies where we have kids who are overweight or obese with prediabetes, and that's a condition where the sugar levels are higher than normal, but not yet high enough to diagnose diabetes, so it's sort of in the borderline zone. If these kids continue to gain weight, they can quickly progress to type 2 diabetes, whereas teens who can maintain or lose weight can actually go back from prediabetes to normal. And there's many different levels of intervention. I think on the physician level, it's all about early detection of risk. So regularly assessing weight status and monitoring for any complications that come with obesity, which includes diabetes. And there are clear guidelines from the American Academy of Pediatrics and other organizations about what screening tests should be done. Another obviously critical part of diabetes prevention is for doctors to do detailed histories around diet and exercise and offer appropriate counseling. And counseling is really, the current thinking is that you use the principles of something which is called motivational interviewing, which is an interactive technique, and it's really focused on gauging motivation and confidence by talking about different types of behaviors, personal goals, how ready kids and families are to actually make changes, how important they think it is, and any barriers to making those changes, and kind of working together to decide how to go about it. But unfortunately, these individual medical visits are not always enough to prevent diabetes. And so I think, as I mentioned earlier, there's multiple factors that contribute to unhealthy lifestyle. And so I feel like doctors can also play an equally important role in assessing other social factors, things like poverty or food insecurity, and providing resources. And it's really important that we collaborate with social workers and social service programs to make sure that families are accessing whatever resources are available. And also that physicians should be familiar with things in the neighborhood, places where families can get affordable, healthy food or opportunities for physical activity. And I think doctors can also serve as advocates by lobbying policymakers and others, just in terms of promoting healthier environments in general. So this work actually started in the adult population over a decade ago. We use a method called community-based participatory research. And this is a research method in which researchers and community members are equal partners in developing and implementing research. More than 10 years ago, these community and academic partners developed a diabetes prevention program for adults in East Harlem, focused on adults with prediabetes, and they did a large trial with over 500 adults that showed that using trained community health workers or peer educators to run diabetes prevention workshops were successful in promoting significant and sustained weight loss and other measures of diabetes risk. And so my research focuses on adapting this model for adolescents. We did a lot of work in the community by interviewing community youth leaders and doing focus groups with kids, and really reviewing the adult program that I had mentioned, as well as other teen programs, and modified the program to make it age appropriate, which includes lots of interactive activities like games and group exercise. And we worked with community partners. So it was following this community-based participatory research model, developed a community advisory board that includes community members, youth leaders, youth themselves, along with the researchers and academic team. And we worked together to recruit East Harlem teens from community organizations, health centers, and schools. And we screened the kids for prediabetes, and we did some body measurements. We checked their blood pressure. We did blood tests. We did a survey. And we identified, out of the about 150 teens that we tested, 90 of them actually were diagnosed with prediabetes and were enrolled into the study. We used a design where about half the kids received the program and the other half were in a waitlist group, so they ended up receiving the program after we did their follow-up visits. The program itself was a 12-week program, and the kids would meet for about an hour and a half weekly over the 12 weeks. And our diabetes prevention workshops were also peer-led, so we trained young adults to actually deliver the program. And the workshop included things like behavioral skills, like setting goals or monitoring behaviors, doing problem solving, how do you cope with difficult emotions, social support. And then we also talked about topics like, what is prediabetes? How do you read a nutrition label? How do you plan a healthy plate? What are appropriate portion sizes? How do you find affordable, healthy foods? And then physical activity, strategies to increase activity in your regular day, simple exercises that you can do at home. So all of these were done under the supervision of adult health educators, but were actually implemented by youth peer leaders. And then we collected follow-up data. And what we found was that certain body measures stabilized, so they were maintained. We did see that waist circumference, which is sort of a measurement of how fat is distributed in the body. And we saw that there was a increase actually in both groups, but a smaller increase in our intervention group of 2 centimeters compared to the control group, which had an increase of 6 centimeters. And this is important because we know that body fat that's in the central part of the body is associated with a higher risk of diabetes and other things. And then we also did some blood tests. So we found that fasting glucose and hemoglobin A1C, which is a test that gives us information about the average sugar levels over the past 3 months, both of those decreased significantly in the intervention group at follow-up. And we also saw that total cholesterol and LDL, which is what we call the bad cholesterol, decreased at both follow-up time points in the intervention group, while HDL, which is the good cholesterol, actually decreased at both follow-up time points in the control group. So all of these findings pointed to some promising trends in terms of clinical outcomes. And we also saw some interesting results in terms of behaviors, like in the intervention group, we found a decrease in frequency of snacking, eating ready-made meals, eating in foods and drinks from food stands or fast food restaurants, and some other promising behavioral trends. So these are things that we'll continue to study with upcoming groups that take part, of teens who take part in this program. Sure, I think there's a lot of things that make this research and this program unique. The first thing is the overall strategy for the research, which is this community-based participatory research model. And specifically that we included youth and young adults at all levels in the study. So obviously we had teens as the study participants, but we also had young adults who were the peer leaders. We had interns and study coordinators, so our research staff were all young. And we also had younger members of our community advisory board, so the community academic partnership that oversaw the study. And there were actually youth that took part in the study at some point, either in a focus group or in the screening, or in the, and they actually ended up joining our board. And we've actually done interviews about this aspect of the study and have heard a lot of unique perspectives about young people being involved with research. Going along with that, I think just in terms of building skills among young people, empowering them that their voice is powerful and that they can make a difference, and then promoting advocacy among youth, which is understanding that young people can actually actively support efforts to make their local environments healthier, doing things like starting a campaign in their school to remove vending machines, or doing things in the community like starting a running club or talking to a bodega owner about selling healthier food. So we try to essentially incorporate youth and provide them with a lot of skills that they can use to help themselves and hopefully their communities. I think the other unique thing about Teen Heat is that it uses this peer education model. So we know that young people are more likely to change their behaviors if the person who's talking to them is similar to them and has sort of dealt with the same concerns and pressures. And this strategy has been effective historically in other areas like sexual health or smoking cessation or substance abuse prevention. But we know that peers influence young people on things like physical activity and diet. And there haven't actually been as many peer education interventions specifically for diabetes prevention. So that's something that the Teen Heat program uses, and that it provides an important opportunity to include youth as partners in this type of research. The other thing is just around technology. So we know that any interventions that target youth often struggle to keep the youth engaged, and that mobile health technologies, things like texting and apps and social media, there's potential to use tools like this to actually incorporate them into these types of health programs. And specifically, we know that teens from lower income households are just as likely to have a smartphone, and so that we can try to use these types of technologies to engage vulnerable youth and address these health disparities. So in this study, we worked with younger members of our community board and a partner technology company, and we developed a novel interactive text messaging program. And it includes automated and manual messaging around goal setting and behavior tracking, giving individualized feedback, motivation. So we just finished pilot testing this program, and we're planning to refine that and using it with new cohorts of teens that enroll in Teen Heed. And the other interesting thing that's going on in terms of technology is around virtual programming. So we know that based on our pilot study, that as we're starting to think about how we can increase program access and attendance, that we wanted to start exploring ways for delivering content virtually. And then in the spring of 2020, at the start of the COVID-19 pandemic, it became even more important to figure out how to continue this program when we can't necessarily bring together groups of teens in person. So we're now in the process of adapting our entire 12-week curriculum for delivery on Zoom, and we're going to be doing a pilot of the virtual program, and we'll try out activities with teens that were enrolled in the in-person group so we can get their feedback, and we plan to enroll new cohorts of teens to take part in the virtual program with the text message support in 2021. So we're really excited about that. So I think it's important to recognize that rates of prediabetes and type 2 diabetes are continuing to increase. There's no easy solution. So we have to develop strategies at all levels. This includes individual interactions with patients and families at medical visits. It includes advocacy for healthier schools and communities. And it includes community engaged research, like our research. It's not easy to figure out effective strategies, and it's critical that we have ongoing support for this type of research so that we can develop effective models for youth diabetes prevention. And it will have long-lasting medical, public health, and economic impacts if we don't do something to address diabetes in young people. And so we hope that we'll continue to learn more so that we can support kids and families as they're trying to become healthier.